Hello, everyone, and thank you so much to Dr. Morgenstern for his excellent overview. My name is Donna Lidwinski from Solving Kids Cancer, and I'll be moderating this session entitled The Challenge of Curing High-Risk Neuroblastoma. This is going to be delivered by a pre-recorded session by Professor Jan Molenaar. He's a principal investigator at the Prinses Maxima Center for Pediatric Oncology and professor at the Department of Pharmaceutical Sciences in Utrecht University. Also, Dr. Rajen Mody. He is a director of Pediatric Developmental Therapeutics and Precision Oncology Program in Michigan Medicine. Dr. Sara Federico, who's the associate member, Division of Solid Tumors, Department of Oncology at St. Jude's Research Hospital, and Dr. Stephen DuBois. He's the director of experimental therapeutics at Dana-Farber Boston Children's and associate professor of pediatrics at Harvard Medical School. I also want to point out that we have a pre-recorded session by Dr. Brian Kushner from Memorial Sloan Kettering. He discusses the new induction protocol at Sloan Kettering, and that is available in the resources section now, and it will be available with the rest of the videos as well. So before I hand it over to the first speaker, I'd like to point out that we do have a chat function, which you can see. Please feel free to put your questions in there, and we'll handle all the questions after the presenters are done. So our very first speaker is Professor Jan Molenaar, and in this pre-recorded, he'll be joining us during the question and answer session later. So over to Professor Molenaar.
Yes, good afternoon. My name is Jan Molenaar. I'm from the Prinses Maxima Center in Utrecht in the Netherlands. And I'm really honored that I can speak in front of this audience, which I really appreciate, specifically not for me, but also because of the feedback that I'm getting from the audience, which of course, in this case, I'm not getting. So thereby, I really regret it that I can't be there live. Sadly, I have other educational obligations. So actually, I'm teaching right now at this moment students, and I couldn't change that. So sorry for that, but really appreciate to show a part of my work that we're doing. And what I would like to present you is the current development on precision medicine. So more specific treatment for children with cancer. So let me start my presentation. Share screen. There it is. So it's all about finding the right treatment for the right patient. The current treatment of neuroblastoma patients is looking like this. So it differs a bit per country. There's several trials and changes constantly ongoing, but in general, in the Netherlands, it looks like this, and other protocols more or less are the same. So there's first 6 courses of high-dose chemotherapy together with radiation, then surgery, then a very high dose of chemotherapy, which kills all your white blood cells, and you get an autologous stem cell transfusion, and then anti-GD2 and retinoic acid. And this is the treatment we give for high-risk patients. And you can discuss and debate that and say, isn't this too toxic and too aspecific for this patient? But still, with this treatment, currently, we can cure about 50 to 60% of neuroblastoma patients. So there's clear benefit there. But still, in a fraction of patients, the tumors do not respond properly, or they do respond, they seem to disappear, but then relapse. And these relapses or refractory tumors are very hard to treat. And that's what eventually a lot of patients still die from. And of course, as said, this core treatment of high-risk patients contains toxic and chemotherapy compounds that do target the tumor, but not that specific. And they also damage the child extensively. So what we would, of course, like to do is to have a more specific treatment that specifically targets the tumor cells and leaves the child unharmed. And these are currently being trialed in patients that have relapse refractory tumors. So for this, to have these specific treatment options, we need to know certain things. First of all, cancer is caused by DNA aberrations, by damaged DNA. In every cell of your body, those billion cells, in every cell there's oh no, that's not fitting, no. There's 1.8 meters of DNA folded up in that nucleus of every single cell. And if something damages in that DNA is replicated all the time while cells are dividing, and during replication or in between replication, DNA can damage. And if that happens at the wrong time, at the wrong location, a cell can deregulate and start growing faster and faster, dividing. There's more DNA aberrations compiling, and eventually it's a fully malignant tumor cell that divides, spreads throughout the body, and then eventually it can kill the patient. And the idea of precision medicine is now to specifically target these DNA aberrations, so these genes that are damaged in the DNA, and thereby killing specifically the tumor cells while leaving the child unharmed. And this is actually a picture of a precision bombing of the US Army. So that's the way we would like to do. For that, of course, you have to know what the DNA aberrations are in these tumors, and that we can currently do. We use for that DNA sequencing, advanced sequencing techniques, and that gives us information about all the DNA aberrations in these tumors. And this is currently frequently presented in a certain kind of way, which is called the circus plots, which is shown here. So this is a representation. This is not as it looks in the tumor. This is just a figure to show what the aberrations are. But we align all the chromosomes, so all the DNA in a circle, and then indicate where the aberrations are. And you can see that here's pieces of DNA that are lost, while there's extra copies here. And these two genes are strongly amplified. That's MIG-N and ALK in these patients. There's mutated genes, there's translocations. So all these genomic aberrations for this specific patient. But every patient, neuroblastoma patient, has unique DNA aberrations. Every tumor is different, meaning that if you want to give a treatment against these DNA aberrations, you have to sequence and to analyze the DNA of every individual patient. So that's where these precision medicine programs are currently based on. So the precision medicine programs, several have been started now and are ongoing in the world, various in different countries. Starts with a relapse patient. So there's a tumor that relapses or is a refractory for treatment. And the patient is then entered in the precision medicine program. A biopsy is taken, or a surgical specimen is taken from the tumor. DNA and RNA is isolated, and that is then sequenced, and the data is processed and analyzed, which generates these type of circus plots, as I said. And that data is then discussed in a tumor board, molecular tumor board, or a general tumor board, where there's physicians, molecular biologists, pathologists, researchers, clinical trial doctors, and they identify and discuss the genomic aberrations and relate that to potential new therapeutic interventions, new medicine that actually fit exactly to these DNA aberrations. And based on that discussion, there's eventually an treatment advice, whether the patient could go into a trial or whether there's compounds available that are not in trial but could be given off-label or based on compassionate use, so by the company to be used for that specific patient. So there's all types of genomic aberrations that we can identify, and a few examples. So, for instance, if we identify an ALK mutation, yeah, the ALK mutation is a. Oh, wait, let's go back. There's an ALK mutation detected in a patient that is a mutation against which there are therapeutic options. Yes, it's a DNA aberration, so that means that it's a strong aberration. There's compounds specifically targeting ALK, so we prioritize further. ALK inhibitors have shown to be quite effective, and specifically in neuroblastoma tumors. So we end up with a very high priority target. And then we can advise for this patient the lorlatinib trial in combination with cyclotopo, which has got this number. MYC amplification. So there's amplification of this MYC gene. It's where's my arrow? Yeah, there it is. So it's a DNA aberration which is actionable. It's DNA aberration, but there's no compound specifically against MYC. There is a compound that might work at tumors with MYC amplification, but not specifically targeting that gene. So that deprioritizes, and then you end up as an intermediate target. So if there's a MYC amplification and an ALK mutation, you prefer to put the patient in a ALK trial instead of something against MYC. Next one, BCL2 overexpression. Interesting target, and there's compounds available, but it's overexpression. It's not a DNA aberration. It's actually just a gene which is turned on. So that deprioritizes this compound. It's a good target. There's quite some evidence that it works, specifically in neuroblastoma. So also here, an intermediate target. And we could advise the idasonitline venetoclax trial, where venetoclax is specifically targeting BCL2. So in this way, you can specifically identify genomic aberration, relate that to potential therapeutic interventions, and give an advice which treatment to continue with. And there's various programs currently ongoing, per country organized. So we've got the MAPIAX program in France, Inform in Germany. In the Netherlands, we have the ITER program, SMPAID in the UK. The Danish have a program, Zero in Australia, and there's several programs ongoing in the United States. This is, of course, sounds very, very tempting and promising, but you need to have genomic aberrations that you can actually target. And if we study larger populations, what turned out is that in about 50% of the patients, I think in neuroblastoma slightly less, but still a significant part of the patients, we do identify genomic aberrations, but there's no clear therapeutic options that fit to that DNA aberrations. So for that, we have now expanded, and we've done that, and several other labs have done that, expanding the precision medicine program. So we take the biopsy, still work it up for DNA, so this is the normal part of the program, but then we also take a part of the biopsy and dissociate the cells, and then try to expand them. So these cells, these tumor cells, are very malignant, so they grow and they expand. And we then plate them out, and then we have a pipetting robot, and we pipette about 200 different compounds that are currently being tested, that are currently in trial, specifically on the tumor cells of that patient. And then we test which of these compounds are actually killing the tumor cells. And thereby, even if there's no genomic aberrations, we can identify compounds that potentially are effective in these patients. And this is still research. I think the DNA analysis is more or less becoming part of the standard diagnostics in most countries. The compound testing on the tumor cells is still experimental. So we do not know how well this predicts whether a compound will eventually work in a patient. So real scientific work still to be done here before we can actually use that in a clinical setting. So this is where we're going. Of course, this is what we're currently doing for the relapse patient. So if the tumor returns, so that's where we're trying these new targeted compounds. But what you would, of course, like to do is to move this up front. So if you identify genomic aberrations up front, then immediately start treating the patient to prevent these relapses from occurring. And that's what's actually happening. So one of the compounds which I just shown, the lorlatinib, which was tested in these relapsed tumors, is now going into an upfront setting. And I think that's a really big achievement, which was strongly supported by several organizations that also organized this meeting. So Solving Kids Cancer is supporting this. So this is the Titan trial, which is a trial using the ALK inhibitor lorlatinib in an upfront setting in neuroblastoma patients. So newly diagnosed patients, DNA analysis upfront, determine the ALK mutation status. If there's an ALK mutation, you will go into a trial with the ALK inhibitor. And this is going to be a transatlantic trial, so it's going to be in the US and in Europe, which sounds very logical, but is actually logistically a great achievement. So having said that, we're making steps. We're going towards a better and targeted treatment. It is still a lot of work to be performed, and still we need to learn a lot and become better. We're not there yet, but this is the way we're going. The first compounds are now entering in the upfront setting, so this is really where we want to go, and thereby we would like to improve the curation rates of children with neuroblastoma and cure them better. So leaving the child unharmed, do not damage the child. Hope to reach that in the future. Thank you again for allowing me to present here. It was a pleasure, and next time I really hope to be there live. Thank you again, and I hope you will enjoy the rest of this session.
Well, many thanks to Professor Molenaar for that excellent presentation. Now we're going to switch the order a little bit and have Dr. Sara Federico present on extended induction. When is that a good idea?
Great. Can you, oh, there we go. Great. So good afternoon, everyone, and thank you for allowing me to present today is extended induction right for a subset of patients with neuroblastoma. And so as you all know, therapy for high-risk neuroblastoma is multimodal, and unfortunately, we still lack great biomarkers that guide clinical decision-making while the patients are receiving therapy. And so one of the questions that many investigators have wondered about over time is whether early response to therapy is related to outcome. And although it seems like a fairly straightforward question to answer, unfortunately, it's not due to the following reasons. So first, evaluation of response and the response criteria for patients with high-risk neuroblastoma has actually changed over time. And so while the international neuroblastoma community has made amazing strides toward aligning the classification of response by establishing an international neuroblastoma response criteria, that's called the INRC, imaging modalities and bone marrow disease quantification have changed over time, which has actually led to a revision in assessments. And so today we currently use the revised INRC to assess for response in high-risk neuroblastoma, in which response is assessed in 3 different components that are shown on the slide, including the primary tumor response, the bone marrow response, and then the metastatic and soft tissue disease response. And so together, these individual component responses are then used to determine an overall composite response. A second reason that it's been difficult to determine a potential early indicator of response is due to actually a paucity of data or lack of data about the individual components of response on prior studies. So for example, the primary tumor, bone marrow, and metastatic soft tissue disease responses individually were not collected on prior studies. Rather, an overall response was collected. And so historically, patients who have achieved a response of stable disease or better at the end of induction have been eligible to remain on study in the US and continue to get subsequent therapy. However, the clinical experiences that many of us were feeling is that the patients who had a poor response to induction therapy ultimately had a poor outcome. And so Dr. Naveen Pinto and colleagues actually sought to answer this question, and they retrospectively looked at predictors of differential response to induction therapy in patients with high-risk neuroblastoma. In this study, they evaluated over 1,200 patients from 4 consecutive COG high-risk trials. Response was evaluated by the 1993 INRC criteria. So in this analysis, the end of induction response that was less than a PR, which is also known as a partial response, was associated with a significantly lower 3-year event-free survival of only 21% for those patients in comparison to patients who had, at the time of end of induction, greater than or equal to a PR, a 54% response rate. And for overall survival, this continued in that patients who had less than a PR at end of induction response had an overall survival rate of 46% versus 73% in the patients with an end of induction PR or greater. And so this data really confirmed what we were seeing clinically, and it identified a group of patients that may truly benefit from alternative treatment strategies. And so what could those alternative treatment strategies be? Well, therapeutic MIBG has been a treatment strategy used for a number of years with variable success depending on the study. So the most recently published NANT study by Dr. DuBois, who you'll hear from a little while later, evaluated 3 different MIBG treatment regimens, including MIBG alone, MIBG plus vincristine and irinotecan, and MIBG plus vorinostat. In this randomized phase 2 study, the patients who received the third combination, the MIBG plus vorinostat, had a response rate of 32% in comparison to the other 2 arms, which had a response rate of 14%. And again, this is in patients who had relapsed or refractory neuroblastoma. And as we now know, one of the biggest therapeutic advances for patients with relapsed or refractory neuroblastoma, seen on the right hand of the slide, was the successful irinotecan temozolomide dinutuximab regimen evaluated on a randomized trial AMBL 1221, in which the initial cohort of patients with recurrent or refractory neuroblastoma who received the chemotherapy with dinutuximab had a 53% response rate compared to the treatment arm that received irinotecan, temozolomide, and temsirolimus. And Dr. Mody, who will be on later, he was the PI of this study. And so in the setting of successful treatment regimens for patients with relapse or refractory neuroblastoma, physicians now have had the opportunity to alter therapy off protocol studies that may be beneficial to a subset of patients who are experiencing a poor response to induction therapy. But historically, this has not been evaluated. And so truly our neuroblastoma community lacks the data to know if the addition of alternative therapy, so that's kind of extra therapy between induction and consolidation, is beneficial to some patients. And so Dr. Ami Desai and some of her colleagues from 6 different centers around the United States sought to assess if post-induction therapy, so this is also called bridge therapy, was effective in the treatment of patients who had end induction residual disease. And so what this group did is they performed a retrospective review of patients with high-risk neuroblastoma who were treated at the 6 institutions. These patients were diagnosed between January of 2008 and December of 2018, so a 10-year time span. The patients evaluated on the study in order to be included in this data set could not have had progressive disease during induction therapy, and at the time of end of induction disease evaluation, their end of induction response needed to be a PR or worse. So that includes a minor response and also stable disease. The response was assessed after induction if the patients received bridge therapy, after the bridge therapy, and then also at the end of all induction regimens. And then there was a separate analysis that was performed for patients with stage 4 disease, in which the investigators assessed the metastatic response of these patients. So patients were stratified into different treatment cohorts, and the data was evaluated. And so here are the 3 cohorts. So the first cohort, cohort 1, you can see labeled on the left hand of the slide, included patients who received standard induction therapy, consolidation, and post-consolidation. So this group did not receive any additional therapy. This group, you can note, was definitely the largest, the bulk of the patients that were evaluated, with 123 patients included in this cohort. And it's really important to note when we think about this data on the right hand of the slide that only 3% of the patients that were included in this first cohort actually had stable disease in their sites of metastatic disease. So stable disease in their metastatic response. Cohort 2 included patients who received standard COG induction, followed by what we're calling bridge therapy, which in this case was most often the combination of irinotecan, temozolomide, and dinutuximab, but also included patients who had MIBG or a combination of the two or occasionally different chemotherapeutics. Those patients then went on to receive transplant and post-consolidation, kind of in the standard COG way. So there were 51 patients included in this group. And again, it's really notable on the right hand of the slide where you can see that actually about half of this group at their end of induction had stable disease at their metastatic sites of disease. So again, very different group from cohort 1, in which most of those patients had better than stable disease in their metastatic sites. And then the final cohort included in this data set were patients who received the standard induction, followed by some sort of post-induction therapy that did not include transplant. And so a smaller group of patients, there were only 27 patients in this cohort. And similar to the cohort number 2, you can see on the right hand of the slide, approximately half of these patients at their end of induction evaluation had stable disease at their metastatic sites. So now let's take a look at the data that Dr. Desai and the group presented. And so here are the event-free EFS and overall survival OS curves for the 3 cohorts. And just to orient you for the next few slides, the event-free survival curves will always be on the left hand of the slide, and I've put them in a red box, and the overall survival curves will be on the right hand of the slide. The x-axis goes across the bottom of these, and it is represents time from years from diagnosis as you move to the right. And then the y-axis is the percentage of patients being evaluated. And so in these curves, you can see that there was a statistically significant difference between the 3-year event-free survival of when you put cohorts 1 and 2 together compared to cohort number 3. And so again, this is a really important finding because as we discussed previously, cohort 1, those patients only had 3% of patients who had stable disease at their metastatic sites of disease, whereas cohort 2 actually had about 50% who had stable disease at metastatic sites. And so the fact that these 2 groups of patients, cohort 1 and 2, had the same event-free survival is very interesting and kind of suggests that maybe there's some benefit to those patients having received a bridge therapy. And then you can see that the cohort number 3, which is consistent with prior data in which patients didn't receive transplant, they had a worse event-free survival. And so next, when we look at only the patients in cohort 1, so again, those are the 123 patients that did not get the bridge therapy. At the end of induction, 28 of them, so that's about a quarter of the 110 patients who had stage 4 disease in cohort 1 actually had a complete response in their metastatic sites of disease, while the other 3/4 of the patient, 82 patients, had an end of induction visualization of metastatic disease. And so when you look at the Kaplan-Meier curve on the left that's surrounded by the red box, you can see that actually for this group, the patients who achieved a metastatic complete response, meaning that when you looked at their MIBGs, if they had metastatic disease at diagnosis, it was gone, was associated with a significantly improved 3-year event-free survival in comparison to those who had end of induction metastatic disease. So then next, when we move on to cohort 2, again, these are the patients who received standard induction followed by this bridge therapy before going on to transplant. So for these patients who received bridge therapy in cohort 2, 51 of them was the total number. So 44 of these patients, so it's almost 90%, received either the dinutuximab, irinotecan, temozolomide, or MIBG. There were a few that received different combinations of chemotherapy with or without surgery, and one patient that just received radiation. But the bulk of this group received the chemoimmunotherapy or MIBG. And when you look at that event-free survival on the left, you can see that the patients who, after bridge therapy, achieved an overall complete response had a significantly improved event-free survival. And so that's the blue line up at the top that shows those patients that had a complete response following bridge therapy in comparison to others in their group who had a PR in the green or less than PR in the red. And so for the patients who were treated with bridge therapy in this cohort 2, there was also a trend towards improved event-free survival in the patients who actually achieved a metastatic complete response following a bridge therapy. So it's important to note that this wasn't statistically significant. And so that's why it's called a trend toward improved event-free survival. And really, this would require a larger patient cohort to get a better assessment of this. And so finally, when we look at the patients who had stable disease at their metastatic sites at the end of induction in both cohorts 1 and 2, metastatic disease was detected at end induction in 82 of the patients who had stage 4 disease, and in 49, and that's in cohort 1, and in 49 of the patients, which is really almost all of them, in cohort 2. And among those who had stable disease as in their metastatic sites at the end of induction, significantly improved event-free survival at 3 years was observed for cohort 2. Those are the ones that received bridge therapy, as seen by the red curve. And again, the take-home message, I think, from this Kaplan-Meier curve is that patients with end of induction metastatic stable disease who received bridge therapy followed by standard COG high-risk neuroblastoma therapy had an improved 3-year event-free survival compared to patients who had metastatic stable disease at the end of induction that did not receive bridge therapy. And so the authors concluded and noted the following. Number 1, for the patients with end of induction residual metastatic disease. So when you got an MIBG or a PET scan, you could still see sites of metastatic disease. Event-free survival and overall survival did not differ from cohorts 1 and 2. And as I noted previously, we would have expected that the outcome for the patients that were included in cohort 2 would have been worse due to the fact that 50% of them, almost half of them, had metastatic stable disease at the end of induction, which was very different than cohort 1, in which only 3% did. Number 2, for patients with end induction stable metastatic disease, the event-free survival was significantly improved for cohort 2 versus cohort 1, which really suggests that bridge therapy may have benefited the patients. And again, I use the word may. Number 3, there were no differences in event-free survival for cohort 1 and 2 patients with an end induction metastatic PR. And so it's really important to note that the way we assess response for patients is patients who fall in that PR group can have very different burden of disease, meaning amount of disease, to be classified as having a metastatic PR. And so really larger cohorts would need to be studied to determine whether the effects of bridge therapy differ among patients with more or less extensive metastatic disease and or specific disease sites. And so number 4, the presence of metastatic disease before transplant is associated with an inferior event-free survival, which is not surprising. And then finally, the cohort 3 patients had an inferior event-free survival and overall survival when you compared them to cohorts 1 and 2. So the ones did not receive bridge therapy, the 2s received bridge therapy. However, there were 6 patients who actually were able to achieve a metastatic complete response with their bridge therapy, with the post-induction therapy, and did not undergo transplant and all remain alive. And so that's something. Again, it's too small of a number of patients in that group to draw bigger conclusions, but that is what they saw. And so now bridge therapy has also been evaluated in Europe, but with different results. And so in the Cyopen high-risk neuroblastoma 1 study, bridge therapy was evaluated in this prospective phase 3 study. And so the patients who had a metastatic complete response or partial response limited to 3 different sites on an MIBG with no bone marrow disease went on to receive consolidation therapy in the rest of the prescribed therapy on this protocol. However, the patients who did not achieve that response actually went on to receive 2 cycles of a different post-induction therapy or a different bridge therapy, which consisted of topotecan, vincristine, and doxorubicin, so 3 different chemotherapies. So on this study, 23 patients who responded to bridge therapy and then underwent transplant actually had a significantly lower 5-year event-free survival in comparison with those who did not require this treatment. And to be honest, it's really impossible to know what to make of these 2 different groups, the DuBois publication, and then this, because the bridge regimens were actually quite different. And so it may have really been a reflection of the different regimens that were used following induction. And so with all of this data in mind, we now plan to evaluate bridge therapy in patients who experience a poor end of induction response on the next high-risk neuroblastoma trial that will be conducted through COG called AMBL 2131. So the primary aim of this study is actually to evaluate if adding antibodies, so dinutuximab, to standard COG backbone improves the outcome for patients with newly diagnosed high-risk neuroblastoma. And so to orient you to this schema, you can see that at the top box, newly diagnosed patients will be randomized with high-risk neuroblastoma, will be randomized to receive either standard COG therapy, which is arm A, or the standard COG therapy with the addition of antibody, so dinutuximab added to induction cycles 2 to 5. And so this is arm B. But importantly, you can see on the left-hand side of the slide, surrounded in the green box, that the patients who are treated on our standard therapy who either develop progressive disease during induction or have a poor end of induction response, they will actually then go on to receive irinotecan, chemoimmunotherapy with irinotecan, temozolomide, and dinutuximab. And this will really allow us to study these patients prospectively and try and determine if chemoimmunotherapy is beneficial to this patient population. So with that, I say thank you for inviting me today to join this discussion. I truly appreciate it, and I look forward to the panel at the end.
Thank you so much, Dr. Federico. That was an excellent presentation. So next up is Dr. Rajen Mody talking about more about chemoimmunotherapy, and he's presenting from India. Thank you, Dr. Mody.
Okay, thank you, Donna. And Rachel, if I can have first slide. Yeah. So I unfortunately had to travel to India for a family emergency. So if the video stream is little of my apologies. But I'm going to focus my talk on chemoimmunotherapy on the relapse refractory high-risk neuroblastoma and primarily focusing on the relapse side. And if I can have next slide, please. I'm a data safety monitoring board member for YMAP as well as Jubilant and Draxamage. Next slide. So this is a slide that some of you might have already seen. This is the schema from the original trial that we ran when after the initial approval of dinutuximab for the maintenance therapy and approval by the FDA and EMA, COG, and I ran a trial with a randomized trial where we compared a combination of chemoimmunotherapy with the chemotherapy and biologics, and the green arm on the bottom, the arm B, which was the combination of irinotecan and temozolomide for 5 days, and dinutuximab on days 2 to 5, along with the GM-CSF, was the winner arm. Next slide, please. If I can have the next slide, thank you. No, please go back one more. Thank you. So after the initial success of the randomized portion, the trial was closed, and after the original patients, 17 patients were enrolled, where we had a 54% response rate on chemoimmunotherapy arm, and this was the first hint for a success of chemoimmunotherapy in relapse and refractory patients. We added 36 additional patients to make sure that the response is valid in a larger patient population. And so if you look at the rightmost column, overall, there were 53 patients, 51 of them were evaluable, and the response rate for chemoimmunotherapy was 42%, which was definitely way higher than the historical control, and other 42% had stable disease, while 13.2% had progressive disease. Next slide, please. And you can see on the left side here, again, my apologies for slightly small fonts here, but if you can see the progression-free survival, you can see that there is about 28% of patients who had a long and prolonged remission following chemoimmunotherapy, while on the right side, you see the overall survival following the chemoimmunotherapy, and even at 5 years, the close to 55% of the patients were alive and in a stable condition. Next slide, please. So just to put this in a context, Dr. Wendy London, our lead statistician at that time, did a study and looked at all the relapsed patient in an era from 2002 to 2009 and compared them to 2009 to 14, and about 300 patients who were treated before the chemoimmunotherapy era, and looked at these 300 patients who were treated. And these are patients, just to be clear, are all, whether they're first relapse or multiple relapses, they are just not first relapse, but patients who could have multiple relapses. They were treated with all the phase 1 and phase 2 studies available at that time when chemoimmunotherapy not available. And then this is their overall survival curve, and you can see at 5 years close to about 18% overall survival. And then on the right side, I just put from our JCO publication from the chemoimmunotherapy, where you can see that there is a stable overall survival curve from 3-year point on, and at about 5 years, close to 54%. So you can see almost tripling the overall survival. Now, there are historical biases, and the treatment and supportive care have changed, and there were patients in the left side study who had more than one relapse again. So this is not an apple-to-apple comparison, but just in general shows what chemoimmunotherapy's contribution is in terms of improving the overall survival of patients with relapse and refractory neuroblastoma. Rachel, if I can have next slide, please. And so to build on our first study, NBL 1221, COG is currently, my colleague Meg Macy is leading this trial, a phase 2 randomized trial of irinotecan, temozolomide, and dinutuximab randomly compared to IT-DIN plus DFMO. And DFMO, as many of you know, is an irreversible inhibitor of an ODC polyamine, and it has been shown to inhibit MYC-induced translation and improves the tumor-free survival in neuroblastoma mouse model as a single agent as well as in combination with chemotherapy. So this trial is building on what we have shown earlier, and the trial is ongoing. However, there were some issues with hearing loss, exacerbation of hearing loss in these patients when they were receiving DFMO in combination with chemoimmunotherapy, and DFMO supply has been an issue recently, and so I think this trial has now been restricted to maximum of 6 cycles only, and so far 65 patients have been treated on both arms, about 35 and 37 on each arm. Results are being awaited, and this is an active trial. Next slide, please. So what I wanted to cover today is some of the real-world studies. One of the studies that Dr. Federico already talked about, and the number of patients who are being treated on ANBL 1221 and 1821, there are several more patients who are being treated in real world in off therapy in US, where obtaining dinutuximab in relapse setting is not a major issue, and there are several patients who are being treated. And so there were 2 studies recently published. Dr. Federico has already covered the size study, so I'm not going to go into that. And I'm primarily focusing my attention to talking about Ben Lerman and my colleague Rob Bagatell's group conducting a retrospective multi-institutional study looking at the real-world role of irinotecan and temozolomide dinutuximab in a relapsed and progressive disease, high-risk neuroblastoma patient. And just talk about some of the results. Thank you. Next slide, please. So what the CHOP investigator and an investigator from the 16 different institutions were able to show that in this multi-institutional retrospective study, where eligibility included anybody who had relapsed or progressive high-risk neuroblastoma, it does not have to be only first relapse, and they're less than 30 years of age, were eligible. Anybody who had refractory disease, they were not eligible. So this is only focusing on progressive and relapsed disease patients. And there were a total of 146 patients, and 37% of them had MYC amplified disease. Patients who had first relapse or progression accounted for about 2/3 of the patients. So about 1/3 of the patients had 2 or more relapses or progressive disease. Patients, 63% of the patients had measurable disease, and 56% of the patients had prior exposure to GD2 therapy. ALK alterations, including amplification or mutation, will be present in 22% of the patients. And about 23% of the patients also concurrently received additional therapy besides the IT and DIN, which included either RT in form of conventional RT or MIBG, or surgery or other biologic agents. And the letters highlighted in this slide in orange are the differences between the ANBL 1221 compared to this real-world study, where you can see that this is some of these patients with multiple diseases, and patients may have received some other therapy as well. Next slide, please. So if you look at the results, what it showed that the median number of cycle received with this 146 patients was about 4.5 cycles, and the range varied from 1 to 31 cycles. Reason patients discontinue receiving this therapy, 59% because of insufficient response, whether this was a stable disease or progressive disease, 13% because of unacceptable toxicity, 23% because they transition to receive other anti-cancer therapy, while 20% because they completed treatment according to the patient's treating physicians or family's decision. In terms of the response, 49% of patients had objective response to this therapy, with 29% receiving CR, 15% having partial response, 5% in minimal response. This compares to, if you remember from our trial, the overall response rate was 42%, so very similar, slightly higher response. 21% had stable disease, and 30% has progressive disease while receiving this therapy. Next slide, please. In terms of site of response, so when patients had metastatic soft tissue and bone disease, 47% of them responded. If they had marrow-only disease, 73% of those patients responded. In terms of timing of response, median number of cycles before first evaluation was done was 2 cycles, and a range of 1 to 9 cycles. And 72% of the patients had their best response when the first evaluation was done, which is for most of them was cycle 2, while the rest of the 28% of the patient had responses in subsequent evaluation. 13% of the patients who had initial responses, stable disease, had an improved response to either minimal response or PR or a CR. 33% who were deemed to have MR on first eval received either PR or CR, and 41% of these patients who originally had a PR was declared to have a CR. Next slide, please. And in terms of the progression-free survival, the median progression-free survival for this cohort of 146 patients was 13.1 month. 1 year progression-free survival is 51%, and 2 year progression-free survival of 28%, which was very similar to the ANBL 2021 data. Median duration of response from the time of first objective response. So once a patient had an objective response, the median duration ongoing response, in all patients, the response lasted 15.9 months. 1 year progression-free survival in these responders was 68%, and 2 year PFS was 44%. The progression-free survival for patients who responded but ultimately stopped receiving therapy because they completed treatment and did not receive any further treatment was 10.4 months. So they received this therapy of chemoimmunotherapy, and then they stopped after they responded, and their ongoing response was 10.4 months, and 1 year progression-free survival was about 26 months. Next slide, please. There were several patients who did relapse while receiving therapy. 56% relapsed occurred while they were actually receiving the treatment. 31% received after they finished receiving chemoimmunotherapy and they were receiving other treatment, while 14% relapsed after discontinuing chemoimmunotherapy, and they were not receiving any therapy at the time of relapse. Factors predictive for patients who responded, there were a univariate and multivariate analysis done, and all the known prognostic clinical biological factors were looked at, but there were no clinical or biological factors predicted likelihood of response, which was unfortunate. Again, I think this is a sizable study with 146 patients, but there were some hints toward a trend, but I think there were no real smoking guns here in this multivariate model. This study, being a retrospective study in a limited institution, 16 institution study, had several limitations, which comes with the nature of the study and retroactive nature of the study. It had limited institution, which had large institution known how to treat neuroblastoma, so not truly representing a real small center experience. And 23% of these patients received simultaneous other therapies. And so clearly that is a confounder here in terms of counting the actual response rate. Next slide, please. And so I think what are the important lessons that we have learned so far in terms of experience with chemoimmunotherapy in relapsed high-risk neuroblastoma is that results of the clinical trials like ANBL 1221 and the real-world studies like we just talked about, they had very similar results, including the overall response rate and progressive-free survival. Overall, about 30% of the patients remain in long remission 2 years and beyond after receiving irinotecan, temozolomide, and dinutuximab, and ultimately on whether they're having ongoing therapy with any other subsequent therapy. The chemoimmunotherapy does provide sustained response even after it was discontinued by physician or family choice, and ongoing response continued up to a year in majority of the patients. Most responses to chemoimmunotherapy do occur after first 2 cycles, but 30% of the patients do respond, or more importantly, improve their response after the first 2 cycles. There are very few responses seen after cycle 6. So if you had stable disease or worse, you did not respond after cycle 6. What is the optimal treatment if you are lucky enough to respond to IT and dinutuximab? That answer is still not known, and it depends on patients' prior therapy, their biological features, and nature of the response. Next slide, please. Since the Dinutuximab and other anti-GD2 therapy can be potentially toxic. It's very important that we identify biomarkers of response or lack thereof to prevent futile exposure of this toxic agent to young children. And several tumor and peripheral blood-related markers, including tumor microenvironment and through DNA and RNA sequencing, single-cell sequencing, as well as single nucleotide and spatial sequencing to study the developmental stage of neuroblastoma, nature of the immune infiltrate within the tumor, as well as density of GD2 expression. All of this have shown to have some hints of being an important biomarkers, but a large study needs to be done, and I think it will be included in the upfront study that Dr. Federico mentioned that COG is going to run, and these are part of the biomarker panel that will be looked at. There are several peripheral blood markers, including the immune profile for the RNA signature, as well as the NK cell and macrophage analysis, as well as the FC gamma receptor genotype showing an avid genotype, as well as the KIR ligand mismatch genotype, which are shown to be predicting response in small studies in Germany, as well as with Paul Sondal in US group. GD2 and dinutuximab levels also has shown to be of potential interest, and so they'll be looked at in the future study. And I think that was my last slide. And I think, I thank you all for your attention, and thanks for inviting me to this panel.
Dr. Mody, thank you so much for that incredible presentation. Next, we're going to hear from Dr. Stephen DuBois, and he's going to talk about the his paper that was published in ASCO, sorry, lost my place, a high-risk neuroblastoma toward more cures and better outcomes. Thank you, Dr. DuBois.
Thanks so much. Hopefully you're seeing my slides. I'd really like to thank the organizers for inviting me to highlight this review article and also a panel that we had at the ASCO, American Society of Clinical Oncology meeting in June. And it's really an advertisement for this, the article that's freely available. You don't need to be a member of ASCO or have any other privileges. So the focus of the session was really trying to understand all aspects of high-risk neuroblastoma. So I covered the initial treatment of high-risk neuroblastoma, and that'll be the focus of what I discussed today. And then my colleague Meg Macy discussed relapse and ongoing anti-cancer therapy for patients who either relapse or don't have a satisfactory initial response to therapy. And then our colleague, Dr. Tara Henderson, presented survivorship care for those patients with high-risk disease who are cured. So in the interest of time for today, I'm really only going to focus on the initial treatment of the high-risk patient and encourage you to read that review article that includes the full picture, including the relapse and survivorship care portions. And ultimately, of course, what we're all striving for is to make this relapse box much shorter and to make the cure and the quality of cure box much higher. And so I think with my co-authors, we sort of feel as though we're in a bit of a transitional state in thinking about high-risk neuroblastoma, where we're transitioning from a past with a heavy reliance on cytotoxic chemotherapy, where all patients are treated uniformly, and where unfortunately the majority of patients relapsed, with few active regimens available for those patients who relapse, as well as a high burden of late effects in the small population of survivors. And we feel as though we're transitioning to a much more hopeful future state with a greater reliance on targeted therapies, precision oncology approaches, some of which you've heard from Dr. Molenaar today, few patients with relapse, and if they do relapse, that we have multiple active regimens available to offer. And then, of course, a decreased burden of late effects in a growing population of survivors of this disease. So, oops. So just to sort of level set, who are we talking about when we're talking about high-risk neuroblastoma? Well, this slide talks about our current staging system. L1 and L2 both are localized forms of neuroblastoma, but some of those, very uncommonly, but some of those can still be high risk. So in particular, localized tumors that have MYC-N amplification are high risk. There are other smaller subgroups that that can also be high risk. But in general, what we're talking about when we're talking about high-risk neuroblastoma is a patient with stage M or metastatic disease over 18 months. And that's really, in this large analysis from Meredith Irwin, accounts for 72% of all high-risk patients. And of course, our risk classification system matters to determine who's high risk and who's not high risk. So this is a curve that shows the event-free survival rate over time from diagnosis for children according to their risk classification. And so the patients with non-high risk have rather favorable outcomes shown in these top two curves, but the patients with high-risk disease unfortunately continue to have a high rate of either treatment failure or second malignancy. This slide shows our current high-risk treatment paradigm and includes initial induction therapy that consists of multi-agent chemotherapy, peripheral blood stem cell harvest, and surgical resection of the primary site. Patients then move on to consolidation, which consists of high-dose chemotherapy with autologous stem cell rescue, followed by radiotherapy to the primary site and residual metastatic sites. And then post-consolidation, we've heard a lot about the anti-GD2 monoclonal antibodies already that are really critical tools in the treatment of this disease. They're used in this post-consolidation phase, as well as differentiation therapy with isotretinoin. So how has the Children's Oncology Group standard induction evolved over our last series of trials? So these are the trial names here, and these are blocks of therapy, really chemotherapy blocks, and other components of induction therapy like the stem cell harvest and surgical resection. So a legacy trial A3973 included 6 cycles of alternating Vadriac and cisplatin etoposide, and that was then transitioned in ANBL 0532 to incorporate another active regimen, topotecan and cyclophosphamide, that we've known for a long time has activity in patients with relapsed neuroblastoma. And so the goal here was to bring another active chemotherapy combination into frontline treatment. So that was another 6-cycle induction, but included topotecan and cyclophosphamide. And then we conducted a pilot study, ANBL 12P1, that evaluated a 5-cycle induction and showed very similar response rates between a 6-cycle induction and a 5-cycle induction. So we've now adopted this as our current standard induction in North America. And with this therapy, induction therapy, about 80% of patients will have a partial response or better. And unfortunately, about 9% of patients will have progressive disease despite this very intensive therapy. So of course, now we're continuing to work hard to try to innovate for these patients, and that mainly takes the form of early integration of active targeted therapies. So Dr. Federico touched on MIBG therapy earlier, and that remains one of our most active agents. You heard from Dr. Molenaar about ALK inhibitors for ALK aberrant disease. There's certainly now a growing track record of that approach. And of course, anti-GD2 antibodies like dinutuximab or dinutuximab beta. So I have the privilege to lead our ongoing COG trial called our phase 3 trial for children with newly diagnosed high-risk neuroblastoma called ANBL 1531. And in this trial, children are enrolled. We assess their MIBG status and their ALK status. And we use that information to decide where they should be placed on the trial. So patients who have an ALK aberration, either a mutation or amplification, get non-randomly assigned to arm E, where they receive what we view as COG standard therapy plus an ALK inhibitor. All of the other patients move on to randomization, where there's an equal probability that they'll be assigned by a computer to what we consider to be best available COG standard therapy, or to that same standard therapy plus a dose of MIBG therapy. And so for those who like the earlier type of diagram, this for arm B looks like this, having a block of MIBG inserted here after the third cycle of chemotherapy. And for arm E, with the addition of lorlatinib, that started in cycle 2 and continues more or less continuously throughout therapy with a few planned breaks. So that trial has now enrolled over 550 patients, and we expect we'll complete accrual sometime next year. So we've been working very hard together with Dr. Federico, who is here, and Dr. Cash, her colleague, to think about the next trial that will open just as ANBL 1531 is concluding. And so the focus here will, of course, be on chemoimmunotherapy, because that has really transformed the way we're managing children with high-risk neuroblastoma. And so Dr. Federico conducted a successful pilot study evaluating the addition of dinutuximab to our standard induction regimen, and showed that this approach was both tolerable and feasible. And so, of course, the next logical question is, if this is tolerable and feasible, and in the relapse setting shows a very high response rate, will we cure more children if we bring this approach into the upfront setting? And so ANBL 2131 is still in development, but will be a randomized trial where patients are randomized either to the standard, current standard, or to that current standard plus dinutuximab. And so we're very excited to see this trial launch next week, and we'll answer a really critical question in the field. Turning then to the consolidation phase, there's been some recent hallmark findings that are relevant to the high-dose chemotherapy with stem cell rescue that we think is really a pillar of our high-risk therapy. And so in the SIOPEN HRNBL1 trial, there was a comparison between a single BU-MEL transplant, so those are the names of the two drugs that are used as part of that transplant, busulfan and melphalan, compared to carboplatin, etoposide, and melphalan, CEM. And so this randomized trial showed that patients treated with the BU-MEL conditioning had superior outcomes. Around the same time, the Children's Oncology Group, as part of ANBL 0532, also had a randomization evaluating the standard at the time, CEM, versus what we call tandem transplant, 2 back-to-back transplants, one using thiotepa and cyclophosphamide, and another using a modified dose of CEM. And this randomized trial showed a significantly higher response rate cure rate, or event-free survival rate, I should say, to be more precise, for patients who were randomized to the tandem transplant arm. Separately, there was a question in ANBL 0532 focused on the dose of radiation that was being used, and unfortunately did not show that giving a boost of radiation to patients who have residual disease after their surgery, that approach unfortunately did not reduce the risk of what's called a local failure, where the tumor comes back at the original primary site. So the current questions in consolidation phase really are coming from the SIOPEN HRNBL2 trial, where they are comparing in a randomized trial single BU-MEL transplant, which is considered in Europe the standard, versus now tandem using thiotepa, followed by a Bumel transplant in a randomized question. There's likewise a randomized evaluation of the role of boost radiotherapy for patients with residual disease. So this is an ongoing trial, and we are eagerly awaiting the results in several years. In terms of the post-consolidation phase, I'll take you through some of the evolution of how that's changed over the years. So in the trial 3891, my mentor, Dr. Kate Mathey, established the role of isotretinoin as a differentiating agent. So that's 6 cycles of an oral differentiating agent called isotretinoin, sometimes called cisretinoic acid, sometimes called Accutane. It unfortunately has several names, but its official name is isotretinoin. Then, of course, the ANBL 0032 trial was an absolute landmark in the field and showed a significant improvement in event-free survival with the addition of dinutuximab and GM-CSF, alternating with dinutuximab and IL-2, as well as isotretinoin. So that trial, of course, led to the FDA approval of dinutuximab and established a new standard of care. In data that I don't have time to share today from our colleagues in Europe, we reached a determination that the IL-2 cytokine was not contributing to any improvement in event-free survival and was likely associated with increased toxicity. And so in ANBL 1531, where our current post-consolidation includes only dinutuximab and GM-CSF and isotretinoin, and no longer any IL-2. So I like sharing this example because it's the way I like to sort of share how we kind of integrate new information as it becomes available to establish new treatment recommendations for high-risk neuroblastoma. We're continuing to innovate and have an ongoing trial called ANBL19P1, led by Dr. Amit Desai, evaluating the feasibility of giving chemoimmunotherapy, not just immunotherapy, but chemoimmunotherapy that we've already heard a lot about during the post-consolidation phase. So not in the upfront setting, not in a relapse setting, but really during the post-consolidation phase. So patients on this feasibility study receive irinotecan, temozolomide, and dinutuximab, which we consider, and GM-CSF, which we consider a very standard now chemoimmunotherapy regimen, as well as isotretinoin, which remains a standard in the post-consolidation phase. We also have to pay a great deal of attention to disparities in access to care and disparities in outcome based on race, ethnicity, socioeconomic status, or something that is called household material hardship, meaning difficulties obtaining food, shelter, utilities, transportation, those types of very important things that we all need to live, survive, and thrive with or without a child with neuroblastoma. So we have an aim in our ongoing ANBL 1531 to capture household material hardship data and to correlate that with outcomes. We have several other projects in the Children's Oncology Group that's looking at disparities in outcomes based on race and ethnicity as well. We think that this is really important and can have a major impact on our patients. So I'll share with you a paper from my colleague, Dr. Kiribona. This shows the overall survival for patients treated with dinutuximab in the post-consolidation space with 2 curves, one curve for patients who have household material hardship and one curve for patients who don't have household material hardship. And you can see a tremendous difference in cure rates between those 2 groups of patients. And Dr. Bona is working very hard to try to develop interventions to address household material hardship for our patients. So in summary, I hope I've shared with you that we have multiple strategies that are being tested both in North America and in SIOPAN to try to improve cure rates for children with high-risk neuroblastoma, with obviously the goal of bringing this high-risk curve up closer to the outcomes for patients with non-high-risk disease. With that, I will thank the patients and families who participate in our trials, the COG Neuroblastoma Committee, who leads a lot of the work that I shared, and then the tremendous team with whom I have the pleasure to work on COG trial ANBL 1531. Thank you.
Thank you so much, Dr. DuBois. That was a fantastic presentation. And now we're going to move to the question and answer portion of this session. And we will wait for the other panelists to appear. Here they come. Oh, there's Professor Molenaar. Welcome. Thank you so much for joining us. This is great. Well, good. Well, this is actually perfect timing that you were able to come now, because the first question I think applies to you, Dr. Molenaar. The question is, can biology of the tumor change during treatment? Or do you, so the question is, should you be rechecking actually during treatment to see what's happening if new mutations are occurring, rather than get at a point of relapse?
Yes, thank you very much. Do you hear me?
Yes.
Could you hear me? Yeah. Okay. Because I'm also hearing the sounds of the other team, the other room still. I don't know whether that should be, but well, currently I don't hear him anymore. So this is okay. Thank you for the question, and thank you for having me. Sorry for not being live here all the time. I'm actually teaching students, so the new generation that is coming. They're very enthusiastic. I told them, so they're currently having a 10-minute break, that I have to come to you. So a very good question, Donna. And indeed, this is the case. The tumors that are actually constantly changing. So sorry, it's a bit confusing, the sound on the background. I don't know how I can do that. Do you hear the other speakers or not?
We do. We hear some background.
Yeah. I cannot. Maybe sorry for this. Yeah. Okay, they're quiet again. So let me say. So indeed, the tumors constantly change, and they change from the beginning of the tumor initiation until the treatment starts, and also after that, tumors are still changing and they're gathering DNA aberrations. And we and others have shown that indeed, if you look at the tumor before treatment, it has certain DNA aberrations, but much more and additional DNA aberrations after treatment. So that's why in our precision medicine programs, even when the tumor has been analyzed before treatment, we do also, after treatment and before relapse, reanalyze the DNA and see which type of genomic aberrations are there. An example is for instance, the ALK mutation. The ALK mutation before treatment occurs in about 25% of the patients. After treatment and at relapse or refractory disease, we see it in about 25% of the patients. And many of them have occurred during the treatment. So indeed, this is happening, and tumors are changing.
Thank you so much. That's so helpful. The second question is on ganglioneuroblastoma that's a nodular form. The question is, is there a different approach for that? It doesn't seem to be very many cases of that. Does it have a better prognosis than normal neuroblastoma? And so, and please speak up if you feel like that's your question. Yeah.
I can field that. I mean, I think we think of that histology as an unfavorable histology, and manage nodular neuroblastoma identically to to other forms of neuroblastoma. So I think even though it's a rare subtype, we don't think it's better or worse than regular neuroblastoma.
Thank you. There's a related question to that about identifying what might be termed ultra high risk neuroblastoma and different approaches for treating that. Are there any plans to segment out or redefine high risk neuroblastoma treatment wise for some that might be poor risk?
I think there's been a long interest in that. I think we've reached a bit of a conclusion at the moment that that with the biomarkers and clinical features that we have available today, that's available in the clinic. It's challenging to do that, at least at initial diagnosis. I think some of what Dr. Federico talked about related to response-based designation as a patient who will fare less well based on their response. I think we're a bit further along with that. There are some promising additional biologic markers that we might be able to identify at initial diagnosis that could likewise identify a more ultra high risk group of patients. Things like telomere maintenance mechanisms, TP53 mutations, other things that we're tremendously interested in, but not currently collecting on all patients. So can't yet use as a classifying marker.
And to that point, to add on to what Steve just said, though, as we're putting these questions in clinical trials, we will gather more information in the coming years and maybe be able to tease out some of those patient populations because we're collecting that data.
That's excellent. So Dr. Mody, you mentioned DFMO, the trial that is including higher dose DFMO with irinotecan, temozolomide, and dinutuximab. There's just a general question on what do you think of this as a maintenance drug for high-risk neuroblastoma?
I'm no DFMO expert actually in this, but again, I think it needs to be tested out in a randomized fashion to really see whether this actually has any independent activity. I think there is some hint of studies from other investigators who have done, but again, I think I can't say that I have any particular conviction one way or another. I think it needs to be tested in a randomized fashion.
Thank you. Let's see, our next question, and please feel free, like Dr. Federico, if you have something to add, that'd be fantastic. So the next question is asking about antibodies, so dinutuximab. Is it effective against residual soft tissue disease?
So I can take that one. So it can be, this is where things get a little bit tricky and are tricky with the different clinical studies. So in AMBL 1221, the study of Dr. Mody's, which was conducted in the patients with relapsed or refractory neuroblastoma, there were many of those patients who still had kind of bulky soft tissue, their primary tumor disease. And on those patients, whereas when they received therapy, some of their metastatic disease got better and improved, that if they had a large bulky tumor, it didn't necessarily shrink significantly. And so that affected the way that their response was classified. Because as you may remember, when we were reviewing the INRC, the revised INRC, there's primary tumor, metastatic, and bone marrow. And so actually on that 1221 data, there was an equal number of patients who had stable disease, and a lot of those patients who had kind of big, bulky primary tumors fell into that group. In terms of other sites, I mean, it's also a little bit tricky because the trial looking at naxitamab, that in the approval, by the FDA of naxitamab was for bone marrow disease. And so I think sometimes that has led to a little bit of confusion in this space. So I'm actually just rambling. So to answer the question, which was, can it address soft tissue disease? I think sometimes yes and sometimes no. Do you agree, Rajen?
Yeah, I think I was just going to say I would second that, and especially looking at the ANBL 1221 data from the randomized cohort, the first 17 patients, and then the next 36 patients, the response rate difference between was 54% to 36%. And many of those patients who ultimately were deemed stable disease were the one who had primary tumor, which was not resected or radiated, and they came to this trial after just 4 cycles of upfront chemotherapy. And many of the tumors which had more than 8 centimeter size, and they actually did respond, but not enough to be called as partial response. So they can respond. They probably, this is one of the harder sites to see response when you have bulk soft tissue tumors, especially large primary tumors.
Very good. Thank you. Now there's a question about GM-CSF, and what is the evidence that that is efficacious with antibody, and why is it used in the US but not in Europe?
Donna, sorry, one. I'm not going to answer that one, but I have to leave and go back to the students. So thank you for having me. I'll be going back because they're coming back in.
Okay.
Okay. Thank you, and happy to take any questions by mail if.
All right.
Okay.
Thank you so much for joining.
Bye.
Appreciate it. Yeah. So the question is on the evidence for GM-CSF with antibody, and why is it not used in Europe? I mean, you covered, Dr. DuBois, why IL-2 is no longer used, but this is a frequent question in the.
Yeah, we don't have a great evidence base for this. So when the ANBL 0032 regimen was developed, it was thought that cytokines might improve the activity of anti-GD2 therapy, but there wasn't an arm of that trial that didn't include that didn't exclude cytokines, so that we had a dinutuximab plus isotretinoin only arm. So in North America, we've always in the COG trials have always combined with some cytokine, but we don't have strong data that that's contributing. I think part of the reason it's not administered in Europe is, one, drug availability issues, and two, that I think if we had strong evidence that it was improving outcomes, I think then there would be more motivation to get past those drug availability issues. Sara, Rajen, any other?
Yeah, I was just going to say there is so. I agree with Steve that a randomized study would have been the best way to assess this. There is some clinical data from the group out of Memorial Sloan Kettering that GM-CSF may contribute, but again, single center, small numbers, and so clearly not the robust data set that you would have in like a randomized study. And then in the laboratory, there's some data, but that's kind of where things stand.
Yeah, and I think the only thing I would add to both what Steve and Sara said is that unlike IL-2 administration, where it seldom resulted into delays or capillary leak and other complications, GM-CSF has doesn't seem to be detrimental into administration of this chemoimmunotherapy combination. But without the randomized trial, we cannot fully answer that question.
Very good point. Now, there are 2 questions on bone marrow disease. And the first one is it possible to have, I'm assuming they mean a metastatic relapse without having bone marrow disease? And then the second one is, why are bone marrow biopsies not done post-treatment unless there's a suspicion of a relapse? Interesting question.
Go ahead, guys. I think if you, but I'm not sure about the second part. Like, why are they not done? They are being done. So I'm not sure of there might be institutional practices at some places, and so they may not be doing it that frequently. But I think a periodic assessment at some frequency is being done for the bone marrow involvement, for when a patient shows any other progression at other sites to complete the evaluation. So, or when you do MRI or MIBG and it's showing some of the marrow showing up activity, they are being done. So there are some other surrogate. MRI is actually a very, very good scan. Actually, if you really have a extensive MRI studies, sometimes you are able to see. And so I think sometimes it becomes a quality of life, anesthesia needs and other things, and a practical consideration. But I'm happy to have Sara and Steve.
So on the COG studies, after the completion of therapy, the bone marrows are obtained, as you said, Rajen, if a patient is symptomatic or there's concern for a relapse. And that is, as you mentioned, part of it is related to quality of life and the fact that you're also getting, these patients are having the scans, whether it's an MIBG or a PET scan. And oftentimes patients, when they have bone marrow disease, will be symptomatic. And so the decision was made to take those out if they have cleared their marrow and don't have signs of progression, to preserve quality of life, knowing though that there's a very low, if you're suspicious of recurrence, of course, you can obtain a bone marrow aspirate biopsy.
Well, and related to that, when do you see, how soon in the future would you see circulating tumor DNA replace maybe bone marrow biopsies for, some sort of surveillance?
I can speak to that. I mean, that's an area of tremendous interest. We have a big effort as part of the ANBL 1531 frontline trial to look at ctDNA and have thousands of samples already being analyzed. What we see is that this population of patients has a high level of ctDNA at initial diagnosis, and we're very keen to look at the end of induction. What is the ctDNA burden? Can we predict based on the ctDNA burden who's going to do well, who's going to not do well, and to what extent does the ctDNA level correlate with what we see by MIBG scan, by what we see on bone marrow biopsies, and of course on CT and MRI. So there's a tremendous amount that we still need to learn. I think we will have the data that will help us understand how to use ctDNA, but ANBL 1531 is still accruing, and so it'll be a few years, I think, before we have that information.
Well, that's great. That's very exciting. Let's see. We also have a question. Let's see, we covered that. I think this is an interesting question. You touched upon this in terms of response to soft tissue, but what is the strategy if surgery is simply not possible? How do you tackle that in the clinic?
I guess, is it in the relapse setting or is it in the newly diagnosed?
I'm assuming this is a primary tumor that's just not resectable.
Yeah. So, neuroblastoma is different than some of the other solid tumors in pediatrics, such as like brain tumors, where we know if you don't resect the brain tumor out, it's going to be hard to cure that patient. And neuroblastoma doesn't fall into that category. So the goal of surgery is always to try and debulk as much as possible in the safest way possible, and we don't want to, especially with those tumors that are in the abdomen that often wrap around important blood vessels and kind of encroach on different organs. In our recommendation is never to sacrifice, say, a kidney or some of the surrounding structures for the sake of trying to get a complete response, knowing that the systemic therapy you're giving will hopefully reach the tumor, that the patients will have radiation therapy as well. And oftentimes you can kind of just have these residual masses where at the end of treatment, they're either not avid anymore on imaging, or they have differentiated and the cancer cells are gone. And we follow those patients. Of course, they cause everyone a lot of stress, and the parents and us as well, right? Like, it would be great if they're gone, but it's very different than some of the other solid tumors, and we never want to sacrifice the other vital structures just trying to get the tumor out. I'm not sure if that's answering the question.
Wow. Certainly highlights how difficult. I mean, it's complicated in the sense that it might not be a threat, but it might be.
And Steve might know these numbers more, but I think about 1/3 of the relapses are in primary site only, and I think and so clearly local control is important. And if Sarah says if they're entangled with major vessels, radiation therapy or some other way to address that is important without compromising kidney, which is important for future MIBG therapy or high dose transplant and other things and stuff.
Yeah.
So.
Yeah, totally agree. I mean, I think the latest data from an INRG analysis we conducted with Q of O is that 80% of relapses have some component of distant failure, right? And so, that metastatic relapse or a component with metastatic relapse is for sure more common than an isolated local relapse. So it really is, as you said, Donna, it's complicated, and it's a balancing act between wanting to get that primary tumor out, but also not wanting to do anything that's going to compromise subsequent delivery of care that we think is super important for reducing the risk of distant or metastatic failure. That's the predominant mode of relapse.
Oh, that makes sense. Now, the next question is about ATRX. The questioner says they're hearing mixed results about using PARP inhibitor with irinotecan, but wondering what your thoughts are on approaches for ATRX, and what do you think?
Yeah. So in the neuroblastoma space, I think what they're probably referring to is, so ATRX is a type of mutation that can be found in a subset of patients with neuroblastoma. Sally George did some very nice work in the laboratory, which showed that neuroblastoma tumor cells that were ATRX mutant might be sensitive to a class of drugs called PARP inhibitors. And so PARP in a cell helps the DNA repair if it gets damaged. And so if you give chemotherapy, and in this case, irinotecan, which is what the questioner is asking about, to damage the DNA and then block the PARP from coming in to fix the DNA, then for some cancers, the thought is that might be beneficial in treating those types of cancers. It has not been evaluated in the clinical space yet for patients, but I think the neuroblastoma community is very interested in it, because certainly this group of patients can have a different clinical type of disease and can be difficult to treat with our current therapies. And again, the findings in the laboratory don't necessarily always translate to our patients, but there is this great work by Sally that shows that neuroblastoma tumor cells can be killed by the irinotecan and ATRX, and PARP inhibitor together. So I know that there are a group of people that their efforts ongoing to try and evaluate that in the clinic for patients with ATRX mutant neuroblastoma.
Fantastic. All right, the next one, we only have a few minutes left, but this question has to do with children who start out as intermediate risk and then relapse as high risk. And it makes me think about the data you showed, Dr. Mody, showing the outcomes of the relapse in the real world data. Is there any data on intermediate risk children who relapse as high risk? What's their outlook?
So if I recollect the number correctly, I think at least there are about 5% of patients who come into the high-risk trial, they actually start their journey as intermediate risk, and then they kind of migrate their way up. as far as I know, first of all, the numbers are so small, I don't know whether we truly know the difference, but they act as like any other high-risk patients. And anecdotally, I can speak of many of the patients I have treated over this last 2 decades. They certainly do not do any worse than the other high risk. I mean, they do receive a lot of other treatment before they come to high risk, so they have a different journey, but they seem to be responsive to high risk therapy once they actually declare themselves. And I guess Steve and Sarah might have more from their upfront studies and stuff, any of their experience.
I don't. I think it's a really important question, and I think whoever asked that question is identifying a gap in our knowledge. I think something we probably need to study.
And somewhat related to that, is there any updates on the outcomes of children with L2 tumors who have SCAs, the segmented chromosome aberrations or alterations? Any information, more information on that?
Yeah, so these would be localized patients who, in the COG, if they're older patients with an L2 tumor, so a more aggressive appearing tumor on imaging, there's an analysis ongoing from Dr. Pinto that's looking at that. He's presented that in a preliminary manner at a prior meeting and showed that patients in that category who have a segmental chromosomal alteration, specifically 11q loss, fared poorly. So he's continuing to work on that analysis. I think there's a manuscript now being submitted, but it's I think an important lesson that helps us understand that we can use some of these biologically based biomarkers to risk classify even rare subgroups of patients.
Well, that's very good. The next question has to do with the Accutane or isotretinoin. Apparently, some groups have decided to leave that out of the consolidation phase, or I'm sorry, post-consolidation. And so what are your opinions on it? I mean, we have COG representatives here, but there are some groups that have decided not to use that. What are your thoughts on that? And is there a plan to continue using it or maybe reevaluate?
I can speak to that because I talked about isotretinoin in my comments. We're planning to continue to use it. We think that there's high quality randomized phase 3 data, old data, but high quality randomized data showing a role for isotretinoin compared to no further therapy. This is the 3891 randomized trial. So we've continued that along, even in the immunotherapy era. So we don't currently have plans to discontinue isotretinoin.
Very good. And we are almost out of time, but there's a couple of more general questions on relapses. Are they all equal? Do you treat a small burden relapse the same way you treat a high burden relapse? Just maybe some general thoughts on how you approach, those situations.
Super easy question, Donna. way to end with one right over the plate. I'm going to leave this to Sarah and Rajen because they really focus their comments on
thank you for that. So I would say, it's really actually hard to know about the outcome of relapsed neuroblastoma in the current setting because, in the not that distant past, we didn't have therapy that was all that effective. Mm-hmm. And so no one's ever really done big deep dives looking at the characterization of, your relapse and how you respond and long-term outcome because we just didn't have great treatment. In the current era, I think that it is different. And when I say current era, I think there are a couple of differences. Number one, for the patients who have some sort of mutation that can be targeted, like an ALK mutation, with drugs, and especially, you know, when we look at lorlatinib as a third generation drug in comparison to the first generation crizotinib, you know, I think that maybe we'll do a better job at, hopefully, at being able to get these patients to respond to therapy and decrease their burden in terms of which patients have disseminated relapse or one local spot. I mean, I think some of that may be related to the what's driving the tumor, or many things we probably just don't even know. So I think it's really an unknown space and a really hard question to answer. I think it's made even harder and more difficult for families because we all approach it, by we, I mean the clinicians, we all approach relapses in a different way, and it's not standardized. And I can only imagine how confusing that makes it for people, because not only is it not standardized in terms that we also don't know, you know, what's the duration of a combination that you should give, and do you get to the complete response, and then how much longer should you treat? I mean, we just don't have this data. It is something that we need to look at going forward. And hopefully now that we have therapeutics that will help, hopefully many of these patients, these are the details that we can try and discern and tease out.
Yeah, that's very good. A large piece of work. Well,
Ron, I just want to add that I think I completely agree with Sarah, and I think the goal always is to even convert the high burden relapse into a smaller burden, or what we call oligometastatic variant, where you actually can take them to further consolidative therapy and others, while you can't do that when you have a very high burden relapse. So certainly the goal is we can't pick our relapse stratification, but I think oligos and low burden is always better. I would say in that sense, just as a clinician, practicing in a pre-chemoimmunotherapy era to now, I think one of the advantages and one of the good news for the community is how many times all of us have seen a relapse with a Curie scores of 17 and 20, and you give 2 cycles of chemoimmunotherapy, and 17 becomes 2. And I think those are the kind of the results that are very encouraging, that at least chemoimmunotherapy helps us to bring it down. And I think many times the remaining area at the primary site or the large soft tissue sites, but the bone marrow clearance with this therapy is very good. And so I think our approach has been, in the new era of chemoimmunotherapy in the relapse setting, is to really attack the high burden with chemoimmunotherapy to clear the peripheral disease, so then ultimately focus on the remaining large soft tissue with some of the local strategies, and try to then address with the consolidative therapy.
Oh, well, thank you so much. I'm sorry that Dr. Federico had to leave, but we're out of time, and we just appreciate all the time you spent with us. Many questions went unanswered. So sorry, but they were a lot of excellent ones. So thank you, everyone, for joining. Please come back in 15 minutes for the next session, and we'll see you in a few more minutes.